Imagine a trauma patient presenting to the emergency department with sudden quadriplegia. They are profoundly paralyzed in all four limbs, yet their initial X-rays show perfectly intact cervical vertebrae. This is central cord syndrome. It is the most common incomplete spinal cord injury, accounting for up to 20%. Effectively treating this syndrome requires moving beyond superficial bone mechanics. Clinicians must map the injury from its exact cellular pathogenesis all the way up through the patient's biopsychosocial environment. Assuming a stable skeletal X-ray means a stable spinal cord routinely leads to misdiagnosis, delayed surgical decompression, and permanent functional loss. As the human body ages, the cervical spine undergoes structural degeneration. The spinal canal gradually narrows, a condition known as cervical stenosis. Over time, anterior osteophytes, bone spurs, form along the front edge of this narrowing canal. Simultaneously, the ligamentum flavum, a thick, supportive band running down the posterior wall of the spinal canal, loses its elasticity. When an elderly patient falls forward and strikes their chin, the neck violently snaps backward into a sudden, extreme hyperextension. This movement forces the thickened ligamentum flavum to buckle inward. It creates a mechanical pincer, crushing the spinal cord between the posterior ligament and anterior bone stars. This sagittal MRI scan demonstrates that precise mechanism. The cervical canal is narrowed, and the spinal cord directly compressed by anterior spondylitic bone spurs. The adjacent X-ray panels confirm this focal compression occurs without vertebral dislocation or acute fracture. The patient's pre-existing anatomy turns a low-energy mechanical force into a devastating neurological emergency. In 1954, Dr. Richard Schneider theorized that this crush mechanism caused bleeding and edema localized entirely within the central gray matter of the spinal cord. Modern histological and cadaveric studies have proven that theory incorrect. The central gray matter is actually spared. The true pathogenesis is a diffuse mechanical injury to large-diameter motor axons in the surrounding white matter. This physical trauma triggers progressive axonal breakdown, known as Wallerian degeneration, extending outward from the injury zone. This damage pattern explains why the arms can be paralyzed while the legs are still capable of walking. This cross-section diagram maps the lateral corticospinal tract. Motor fibers are organized through somatotopic lamination, meaning specific body parts correspond to specific nerve pathways. Medially situated fibers, controlling the arms and hands, sit directly inside the mechanical crush zone. As the compressive force radiates outward from the center, it dissipates. The fibers controlling the legs and feet are positioned laterally, insulating them from the brunt of the trauma. The distinct pattern of paralysis in central cord syndrome is a direct, predictable mirror of the spinal cord's highly specific white matter architecture. Identifying this syndrome becomes extremely difficult when it overlaps with other vascular emergencies common to the elderly population. A 2024 case study by Key and colleagues describes a 73-year-old man presenting to the emergency room with sudden right-sided hemiparesis and facial jerking. Given his age and hypertension history, these symptoms perfectly mimicked an acute stroke. Initial imaging confirmed a small left lacunar infarct in the brain. 2 days into his stroke rehabilitation, his clinical picture rapidly deteriorated. He developed severe weakness in both arms, completely out of proportion to the weakness in his legs. The patient had suffered a minor motorcycle skid a week earlier. That fall induced a concurrent central cord syndrome, which was initially masked by the active stroke symptoms. To cut through overlapping clinical noise, physicians rely on formal motor scoring. A diagnosis of central cord syndrome requires at least a 10-point difference between the upper and lower extremity motor scores on the ASIA impairment scale. They also utilize T2-weighted gradient echo MRI to identify cord edema, formally separating the cervical spinal lesion from the cranial stroke pathology. Anchoring bias on a single, plausible diagnosis easily obscures an aggressively progressing secondary spinal cord injury. Beyond the motor deficits, the syndrome frequently involves severe, often asymptomatic, urological dysfunction. Nearly 94% of central cord syndrome patients subjectively report normal bladder sensation and volitional voiding upon examination. Objective urodynamic data tells a different story. 70% of patients suffer from neurogenic detrusor overactivity. Furthermore, 42% experience detrusor sphincter dyssynergia. The bladder contracts against a closed sphincter, driving pressures to hazardous levels that risk forcing urine into the kidneys. Taking a patient's subjective word on their bladder function is dangerous. Objective urodynamic testing is a mandatory step to prevent irreversible renal damage. Once the lesion is identified, clinicians must navigate a long-standing debate regarding the timing of decompressive surgery. The modern consensus dictates that early decompression, within 24 hours, is necessary for patients showing rapid neurological decline. However, delayed surgery following an initial period of conservative management is viable for patients who remain neurologically stable. Regardless of surgical timing, physical recovery typically follows an ascending sequence. The legs recover first, followed by bladder control, the proximal arms, and finally hand dexterity. Yet, a successful surgery does not guarantee a successful recovery. The ultimate bottleneck to regaining independence is the patient's biopsychosocial environment. A PACE report by Madeline Schneider highlights how older patients facing a sudden, profound physical loss often develop negative coping strategies like deep denial and escape avoidance, actively refusing rehabilitation. This is compounded by a paradoxical danger: highly nurturing social support. When well-meaning caregivers do everything for the patient, they remove the physical struggle required for neuroplasticity. Surgical decompression fixes the anatomy, but achieving functional independence requires aggressively managing psychological resilience and enforcing patient autonomy throughout rehabilitation. Central cord syndrome is a complex, multi-system pathology masquerading as localized upper extremity weakness. A patient's ultimate prognosis depends heavily on specific clinical indicators: being under the age of 50, presenting with higher initial motor scores, and displaying limited T2 hyperintensities on an MRI. Treating the structural spine is only the first step in the clinical protocol. True recovery requires a triad of interventions: immediate mechanical decompression of the cord, vigilant objective urodynamic monitoring, and the psychological restructuring of the patient's autonomy.